Andy, for those people that don't know who you are, could you share your background and how you got to where you are today?
Yeah. Okay. Well, first of all, it's great to have the opportunity to talk, and I think the most important thing to say is where I am today is never where I intended to be, but it's quite a nice place to be, and I think that's really important because I don't think anyone really plans their career, and those days have gone because you don't know what's there. So if I go way back, I grew up in Norfolk. And first in my kind of family to go to university. Dad's good working class, bus driver and whatever. And I think I was probably told at one point, kind of do your best and stay in Norwich, but stay in Norwich. And everybody I went to school with went to work for what was then called Norwich Union, which is now Aviva. No, nothing wrong with that. And so I was one of the weirdos and went off and headed off and did a degree in physics. Loved physics, brilliant thing to do, physicist by background. And if anyone had told me back then that I'm going to be doing what I'm now, which is, healthcare transformation stuff in the UK and around the world, I'd have just laughed because I was a physicist and I worked in the space industry as my first job out of university. Very small company, learnt so much entrepreneurial, technical, and there'll be a theme that I keep saying. I met these people, and they were great, and they created a kind of learning environment. But I did that for about 5 years, small company, and then went into product development in healthcare. But it was a company that made analytical equipment, and I spent a year of my life making microprocessor code. So this really deep kind of machine code that made a tiny mirror that had the parallel surfaces of the mirror were accurate within a fraction of a wavelength of light, and it would go at very accurate speed.
Wow.
That's when I realized I wasn't an introvert, because I was trying to work out why I was exhausted all the time. And then somebody, again, another great mentor, the guy who ran the UK part of that business, said, why don't you do an MBA? Frankly, it was like I was a Jedi, and Darth Sidious had just suggested that I join the dark side. I was being drawn over to the Sith. No. So I started doing an MBA, but a technology management one, because that was kind of okay. I fell in love with it because I learned about me and people and teams and the interactions of people. So I thought, okay, so I did that for 3 years as I was still. I'd moved on from the mirror that was doing this and was kind of managing parts of products and whatever. And and then so came out of that, and I thought, what shall I do? I know, I'll go and be a consultant. That'll be a good. So I thought I'd be a consultant for a couple of years, and that was 25 years ago. Okay. And so then got one thing led to another, and I spent a year in a big pharmaceutical company consulting to them, doing strategy into action stuff. And I had a big kind of, one of the big firms, I won't say which one, big firm who'd done like this strategy that you need to do lifestyle management for healthcare and change, and went through the process, came back, and then somebody said, you know healthcare, don't you? I went, no, I've done a bit of pharma, that's right. No, you know healthcare. Can you go to the Department of Health? And this was at the time when there were really long waiting lists, and there were targets to reduce those waiting lists and bring new technology into healthcare and whatever. These are all themes that are still out there, by the way. So I haven't solved them. But it's not all my job. So that was a very long way of saying I got into healthcare 20 odd years ago, and I keep discovering new areas of healthcare, like you're an area of healthcare, around the world. And it's an infinite thing, because healthcare's job is ultimately to kind of make people immortal, because everyone wants to live forever, don't they? Well, I'm not sure, but everyone wants to try to. So there's all of these different angles about how can you make the years that you're alive better, and more of those years that you're alive. So it's really big, and it draws you in. And I'd say to anyone who thinks, oh, just try healthcare a little bit, you'll either hate it immediately or you'll be in it forever. That was a long answer to how I got here today.
Well, I find it very interesting though that for you to get into healthcare, as you said, it's not something you plan to. But I wonder, what skills as a physicist do you think you've taken from especially studying, quantum physics at undergrad
Yeah.
into your consultancy now?
And actually, great question. So there's something about, well, it's quite handy to be able to count. So I'll give you that. So physicists can count. But the other thing that physicists do is conceptualize things. And so when you've got, healthcare is ultimately messy. Ask any surgeon, that kind of messy. But you look at healthcare organizations, you'd really like them to be like clean from processes, obviously clean from bacteria and those kind of things, but kind of slick, and they're not, because it's about the most complex area you can have, because you've got the biology at one end of the scale, you've got the organization of it, which is, it's not like running an airport, it's not like running an airline, because there's lots of unpredictable things. There are predictable things there, but it's complex. And because it's complex, people try and run it, and then it becomes complicated. What's great about being a physicist is you can take little bits of the problem and go, okay, I know I don't understand this fully, and nobody does, but we can bring some models to this that mean we can abstract it. Once we can abstract it, we can kind of work on that and see if we can make it better. So I've seen cases where, by doing, we'll talk probably later about some of the leadership development I do. There's an individual, or some individuals who work in an NHS organisation not far from where we're sitting today, who came on leadership programs, and we talked about the difference between leadership and management or whatever, and how you simplify it, whatever. And they went and changed their service, and I know the changes they put in place are saving lives, mums' lives, babies' lives, clinical risk is down. So that approach of saying there's a model for something, we apply it, and we understand it, not fully, but a little bit more, we can make it better and get outcomes. I think, I haven't really thought about that. Well, thank you for asking that. But I think that's a really, there's some fundamental skills in there. And being able to count as well. That helps. Yeah, that counts, yeah. There's always counting, yeah.
It's interesting, because I think a lot of physicists, or first, you don't get many physicists that move out of sort of the researcher environment that they're in. So when you go down the physics route, you do sort of stick. But the ones that do make it out to, out of physics, they always mention this idea of breaking something down to a sort of first principles.
Yeah.
Could you share an example of you mentioned yourself in healthcare, there's all these complex problems. What's something you've actually broken down?
Okay, so first of all, I'm going to pick you up on the things not many people escape physics. Not many people who escape physics admit they're physicists. So you often find yourself in in some kind of social setting, which is often, I say this as a physicist, in the background, that you go, okay, so you're a physicist, aren't you? And you go, yeah, I am. Yeah, don't tell me.
Can you tell of it?
Yeah, it's like, anyway. But the point around an example of where we've applied something. Okay, I love this. So years and years ago, this is kind of quite early in my career, and it's kind of, again, on the kind of research side of physics. I got drafted in to do a feasibility study on should a certain healthcare organisation buy a landmark. I won't say which one, but it's a landmark site that had been reclaimed and turn it into a biomedical centre. And it was interesting. Different stakeholders looked at this in different ways, and some sort of, it was a property deal. The property guys are going, oh, you could build so many apartments on it, whatever. And the charity had its charitable objectives, and whatever. And another group could see there was an opportunity to do some amazing research on it. And when you've got kind of different sources like that coming together, I'll give you a British Museum reference in a moment. The Rosetta Stone. Do you know what the Rosetta Stone is? It's not a history test. So the Rosetta Stone comes from, I think it was discovered by Napoleon's troops in Egypt. It's now in the British Museum. And like many things, we won't get, that's a different podcast. And on one side of it, it's in kind of ancient Egyptian script, and another it's in Sumerian. Another is, you can tell I'm a physicist because I don't know what's on the other side, but it's a different language. It's in kind of cuneiform or whatever. But what it is, it's got the same thing written in 3 languages, and it was the key to translating between those 3 languages, because once you knew what I don't know, cuneiform was on one side, you immediately knew what the other ones were, and it was the key for unlocking it. And this is the problem with a lot of these kind of stakeholdery type things. You go, okay, we're all talking different languages. We need a Rosetta Stone that sits in the middle, bit of metaphor, bit whatever. And eventually we got to a kind of a brokerage. I don't know if it had a model in there. I've just used history rather than physics. But you can see that we got a brokerage, and actually now on that site, and this is applied to a number of sites, feasibility, it's something that everyone was just a little bit kind of grumpy with because nobody got their way, but everyone was happy enough to take the project forward. So there's probably some psychology in there as well, but it's often those kind of making it understandable so that actually some of the people there could see that they were never going to get their way because, you know, they were looking for warp speed, and warp speed is not possible.
So it sounds as though your abilities as a physicist almost is also to simplify the problem so that you can translate to all these different stakeholders as well.
Yeah, and I'll go back to what I was saying, that just about any problem in healthcare, be that in patient flow or pathways or technology applied to healthcare, or the physical side of healthcare buildings or research or whatever, it generally comes back to there's a complex problem there, and if we can make it simpler to understand, you will make improvements. If you try and understand it completely, you're probably beyond the laws of physics and the understanding of everything.
Or understanding quantum physics.
Oh, so we're onto superstring now, yeah. And that really is post my time as being a physicist. But that was a long time ago as a physicist. So, but it's there. You never get rid of it. It's like riding a bike.
So something really interesting you said earlier, where you said, so you come into healthcare, you either hate it or you love it. What is it that you love about healthcare? Because you've been in this for over a decade now?
Okay, so I'll give you the standard answer, and then I'll give you. So the standard answer is because it changed people's lives, and it does. It genuinely, like the example I gave you about leadership saving lives, and you go, okay, maybe I'm vicariously a doctor. I know in other versions, in other episodes of this podcast, you've talked to a lot of doctors where I'm not, and so maybe that kind of vicarious need to help save lives, whatever, it sounds very worthy, and it's an incredible thing to do, but I don't have that power. I don't have the healing hands, and probably left it too late to change graph. Definitely left it too late now. But what you can see is whether you're working on a small project like coaching somebody. Small doesn't mean unimportant. So you coach somebody and they come back and go, I've just changed this service and I'm saving lives. You go, it's feeling pretty good. Yeah, good. Okay. And somebody paid me to do it because, the kids and whatever don't, they starve otherwise. But then I've had the opportunity to work at national level. So I've worked in a Middle East, fast growing state. I've had the opportunity to take a big consulting strategy document and turn it into a blueprint for a whole country. And that was 20 years ago. I was part of the team. Right now, on Saturday, I fly to a different North African country where I've had the opportunity to work with just some of the most amazing people, different economic structure, population of 100 million people and whatever, and they're for the first time rolling out universal healthcare, something that I'm going to say something a bit unpopular here because we're sitting in the UK. It's very easy to take universal healthcare for granted in the UK. And it's when you spend time looking internationally, and where here, we could argue that waits are unacceptable, and sometimes the NHS makes errors, and sometimes people go to the wrong part of the health system, or there aren't resources available. But you're not in a position where if your child is sick, you've got to sell your house. And seeing a lot of countries that are taking on universal healthcare, does that mean the NHS can't be better? No, because there's always ways of making it better. But seeing that being rolled out and having the privilege of working with other countries who are experimenting with it, and the first thing you say is don't recreate the NHS, but what can we learn from those 75 years and apply it here? that's affordable and realistic, and also steals stuff. Sorry, not steal in an appropriate way, but kind of, you know, picks up ideas like a magpie would pick up bits of silver, and turns that into a fully functioning healthcare system where people get, you know, a fair degree of care at the point of need. That's amazing. So does that make sense why I'm in healthcare? Because to get to do that and somebody pays me, and certainly for the last 10 years, it's been my independent company, but I've had the opportunity to work with some amazing people. Sometimes I work for them, sometimes they work for me, sometimes we work as a team. I know I keep doing movie references, but it does feel something like an Avengers Assemble kind of moment, that we get the right skills together at the right time to deploy against certain problems.
Well, I think you used a really good term earlier, which was the business of healthcare,
Yeah.
where you had all these different parts
Yeah.
to play.
Yeah.
Do you want to elaborate on?
Business can mean many different ways. You know, it's like, my health is none of your business. Well, actually, it is your, you know, not that I'm going to tell you all of my deepest kind of problems and healthcares, and you know, thankfully I'm pretty healthy, but it's more a case of, particularly in a universal healthcare system like we've got now, it is actually quite a good thing to do, to look after yourself, mainly because, you know, there are things that we can do, that means we can eat a little healthier. I mean, I definitely can, I know that. We can I don't know, exercise a little bit more. Mental health's really important. We can kind of take help on that. So there is the kind of, I've got, you know, while my health is my business, and absolutely it's a very important right that I have the confidentiality, but actually health is everyone's business. Look after, you know, take the steps you can take. To quote the phrase, you know, your genes and your DNA may kind of load the gun, but lifestyle probably fires the gun. So, you know, there's that. So that's kind of one part of business, which is kind of get out of my business, but no. Okay. I think the other one is the business of healthcare. You know, and there's often that view, you know, we've got obviously the pharmaceutical companies that are trying to make money out of this, and you've got, you know, the dreadful whatever, you know, but actually at some point, and I remember having a conversation going back a very, very long way. One of the first improvement projects that I worked on, we were trying to work out what was the benefit of doing a particular change, moving from a 3-day length of stay to a day case for a particular type of surgery. And we had to convert bed days into money. Because do you know what? It costs money to have somebody in a bed, and somebody has to pay for that, whether you're in a universal healthcare systems, public healthcare system like in the UK, or whether you're in, I don't know, somewhere like Qatar, in the top best hospital ever, that's, you know, thousands and thousands of dollars. It costs money. And I had a conversation with an analyst who worked in the NHS, who said, I don't think we should be attaching a cost to a bed day. This is a long time ago. Things have changed a lot since then. I go, how do you pay your mortgage? Well, salary. How does your salary get paid? Well, trust gets some money and pays my salary. So actually we do have to do that, because if you can't have that kind of universal measure of value and cost and store of money and all of those things, it's really hard to do it. Then on top of that, you can say, well, actually, are we doing that in an ethical way? Are we doing that in line with, I don't know, government policy? Are we doing that in line with the laws and the rules and all of those things? And are we doing the best with the resources we've got? And, you know, if you're a private company, you know, you've got a responsibility to the shareholders, but also you've got a responsibility for the kind of ecosystem that you're in, that you don't break it. You know, you don't overfish the waters, as it were. And I think there's a lot of debate about that. There's been some bad cases in the past of business abusing healthcare. But if I look at, say, in the NHS, I can see, you know, there's a lot of people in drug companies who work really, really hard to make sure that good value drugs get deployed in the healthcare system. And I'm working with some inventors and investors, international investors investing in British technology, to have different ways of, I don't know, sensing cancers, or using AI to sense cancers, so that it eases the pressure on the system. And all of these is going to, you know, it's an evolution of technology, but it's business. Because at some point, someone's going to say, if you want me to pay all of these salaries and all this technology, I need to give you a thing. And in return for that thing, you give me money. So it is business. It's okay. It's okay that it's business. But I think those ethical things are really important. And generally, wherever I go in the world, you see people thinking about that kind of trade-off between the business of currency and the business of actually is this looking after the individuals and the populations and whatever. I will tell a little story. No, not that long ago, I used to work for a big equipment manufacturer. I didn't sell the equipment. I ran a consulting business in this one of the biggest companies in the world. Certainly was at the time. And I was there. Now in the UK, if you want to build a scanning centre, radiology centre, CT and MRI and ultrasound and whatever, you kind of look and see who else is around there, how the payers will behave and so on. So that was my psychology, because I've worked in our NHS. And I've done quite a lot of feasibility studies and, you know, and worked with health economics people and whatever. I was talking to an American and I said, so when you're looking at setting up you know, in a strip mall, you're looking at putting a radiology centre in there, do you do a study of what the local needs are? He said, hell no, we just make sure that we've got the best store there and there isn't too much demand locally, because this is not a communist system, Andy. It's a market economy and it's the survival of the fittest, and we're going to have the best thing there is there. And I think it was probably in that conversation, let's go back to it, the kind of penny dropped, that you'll have a different conversation along those lines. And it's one of my acid tests. When I go to any health system, I kind of go, how do you decide how many CT scanners, MRI? And the answer to that question will tell you so much about
examples of what, you know, for example, the CT scan, what different countries might say to it.
Well, okay, well, I gave you an example where here we'll look to see, because most of them, the traffic would be, and the volumes going through it would be state funded. So you look to see, well, is there enough, you know, is the population need around here enough for the pathways, for the, you know, for the economic benefits of the NHS? If you look at, say, the example of the guy I was talking to who was thinking, I'm going to run a business, I've seen in the Indian subcontinent, healthcare there is, I would say it's underserved. I would also say that there is a real entrepreneurism there. So it's underserved, which means there's a market gap, but it also means that if you can be the person who does own the CT scanner, you can focus that to wherever you want. And that's really a, you know, like I say, particularly in the underserved areas, that will have a very different question to possibly if you went to one of the huge population centres there, or in China or wherever, and you'd get a real sense of what the motives are in the health system.
So just to play that back, it's almost, you know, every environment's going to have different factors.
Yeah.
And so that's going to say, as you said, in America, it's more, let's just put the best thing there and then let's see what happens.
Yeah.
Whereas in the UK, let's actually analyze the need for a CT scan.
It will be less market driven and more population driven here. Put it like that. Yeah.
And so for someone like, just out of curiosity then, for that, for the viewers in America where they said, let's just put the best one, has that been good for business to just do that, do it in that?
Okay, I haven't spoken to him for 20 years, so I don't know. I mean, if you look at coming back to the cost of healthcare, if you look at the proportion of GDP that's spent in the US compared to the GDP that's spent in the UK, it's around, in most countries, you know, that graph that kind of goes up that says who spends what proportion of GDP. Well, Americans spend, I don't know, around about twice as much on the GDP of their proportion of their GDP on healthcare, but they don't have universal coverage. Here in the UK, I can't remember, it's about 7 or 8%. It's quite a lot of money. But we do have universal coverage. So I'll let the graphs and the numbers. I'm not going to judge because, you know, but a market-driven economy seems to be less efficient. Yeah. If I put my economist hat on, I've never been an economist. If I put my economist hat on, this would appear to be less efficient than shall we say, a slightly more balanced system.
Sandy, you said something really interesting as well about the universal, the NHS in the UK, and how other countries shouldn't copy it because there's obviously challenges. What are the, well, can we go through that? What are the things that other countries should copy from the NHS?
Okay, wow. This is probably going to make me either very popular or very unpopular with quite a few people. So I think the first element is I've worked in many different NHS trusts, both in England but also in Scotland and
And what is it that you did at these trusts?
oh, it varies. So sometimes it's like patient flow. Sometimes it's about reducing emergency department wait times. Sometimes it's kind of strategies. Sometimes it's leadership development.
And when you say patient flow
Yeah.
and decreasing wait time, what would you actually have to do to achieve?
Wow. Okay. So I'll answer that question and we'll come back to your other question.
Yeah.
So here's the classic one. My local emergency department has a queue outside the door. There must be something wrong with the accident emergency or emergency department. That would be logical, wouldn't it?
Mm-hmm.
But then what you realise, and I really feel for anyone who runs an emergency department, is everything kind of manifests there. So, okay, so if you're in an area that primary care isn't serving your population quite so well, there's not enough GPs, primary care isn't there, or the GP waits are too long, they go, I'll go to my emergency department because you will be seen. So yes, fantastic. And so there's one way that the guys get approached. So you know, and I've had this when you talk to the people who run emergency departments.
Yes.
The other thing is, and I've got this with somebody in kind of my extended friend set. They're in hospital. They're well enough to go home. Actually, here's as I was advised. There's 3 stages if you're in a hospital bed. There's when you're ready to go home. There's when somebody spots that you're ready to go home, and then there's when you actually go home. And those 3 different things could be several days apart. And there could be very good reasons. You know, there could be that you're an older person and your home package isn't available. It could be that you need, you know, certain medications, or you need something else that's stopping you going home. Or it could be the middle one, no one spotted you ready to go home. And I know companies have got some great AI packages and stuff that will help spot those people. Are they routinely being adopted? I'd probably say no, because it just hasn't. Anyway, we'll come back to my friend who's running the emergency department.
Yes.
What happens is, and one of the first emergency departments I was allowed to review happened to be in Sydney rather than in Sydenham. I don't know, pick somewhere else, in Sydney in Australia. And I remember, and the guys just said, I won't do an Australian accent, but imagine this in Australia. He said, do you know what? I've had something like 15 reviews in the last 14 years, or is it 14 or 15? And all of them have shown that the problem isn't the emergency department. And then when you look, you see there's a clogged backdoor, or a primary care problem, or the problems they think they've got, because there's still some in ED. You know, there's not quite somebody standing on the hilltop and go, that bit's broken, because everyone's down in the kind of the muck and the bullets of it, in the weeds of it. Yeah. So where are we going with this? Was this what's good or what's bad? No, what do I do in hospitals, wasn't it? So often it's doing numerical, because I can count. And actually I surround myself with people who can really count, get big data sets, clever people, and usually you can pull some data together. And somebody says, where do you get this data from? He goes, it's your data. It's your data. Things have improved. The internal capabilities of the NHS is improving a lot. So what would I recommend other countries do? Invest in your data system. Invest particularly now in AI, in predictive systems, in ways of pulling it together. You probably don't need AI to do it. It's I can hear a friend of mine going, Andy, it doesn't need AI. If he listens to this, he'll know who he is. And so I think there are some neat things that you could do, but actually there is something really good every so often about standing back. Yeah, in the old-fashioned times it'd be a clipboard, but and just seeing where things are bumping up against other faults, and there'll be some person in the system, and all of their key performance indicators and metrics and whatever will be really bad, and there'll be the person who's beaten up and go, I don't know why, you know, why is there a queue out the door? Why is there? And anyway, it's a complex adaptive system.
It's really, I guess, almost looking at, as you said, being that person that comes in with fresh pairs of eyes.
Yeah.
And just saying, what's the actual problem?
Yeah.
What's the constraint? And then I imagine, as you said, it could be maybe there's not enough primary care, not enough GPs in the area to serve the emergency, and then you create a report, and then you.
Well, yeah. What I do is we work out what's wrong, and then we turn up with a magic wand and go, "Here you go, wave that," and fix it. And this is a really interesting one. I was having a conversation with somebody recently who, and this is quite common when you come to healthcare, and this is, I think, why healthcare draws you in, and there's no escape, because when you start unpicking something, it's like unpicking a big ball of wool, which is just because you know what the problem is doesn't mean it's easy to fix. So it could be we can see that we need another, I don't know, X-ray machine, or we need more capacity in MRIs or something like that, or we need it on a weekend or whatever. Well, you can't just go, pop, here it is, the magic wand joke. Sometimes just because you know what the symptom of the problem is doesn't mean that you know the root cause. And if you know what the root cause is, it doesn't mean you've got a solution. And if you even then get as far as working out what the solutions are you're going to try, it doesn't mean you can fix it, because you change some things and maybe it's affordable and whatever, and you kind of have to listen to the system. There's a great thing, and I'm sure many of the people you work with have come across these. In the olden days, it used to be called the Deming cycle, and now in healthcare, it's usually called a plan, do, study, act cycle. Which so PDSA, and it says, okay, so I'm running my accident emergency department. I'm going to make it better. I've got an idea. I've got a hypothesis. I'm going to make a leap of faith assumption that we haven't got enough. And we looked at the data, and it seems to be, I don't know, the cardiac pathway. I can see that there's people who should be staying in there just a few days, and they're staying in there for many, many days. So we think there's a problem there, or geriatrics or something like that. So I'm going to make a plan. I'm going to run an experiment. See, physicist experiment. Yeah, I'm going to run an experiment. And in this experiment, we are going to try, I don't know, focusing on a discharge lounge and actively discharging people. As soon as you're ready. Remember the three things I said? When you're medically ready, when somebody spots you're ready, and then you actually go, which is we're going to pull those into it, and we're going to do, and sometimes they call it a model hospital. We're going to go and do like the perfect week in here. And then, so you plan your experiment. You go, when I'm running the experiment, I'm going to measure before and I'm going to measure during.
Like any.
Yeah, so plan. And so then, yeah, so you plan it and then you do it, P, D, and then study, which is what has the system told me? And you realize you do all of that and it's not made a single thing a difference. And you go, have I wasted my time? You go, no, actually, that's good, because we freed up those beds, but look what happened. And then when you study, you realize that all those beds have been, I don't know, filled up by people who aren't geriatric, but they're what's called medical outliers when you're the wrong part of the hospital. And so what's happened is like the system has gone and stolen all your gains. But if you didn't do the study bit, you wouldn't know. And then there's something called ACT, and ACT means you either push on with it, which means let's go and do it in some other pathways to work out why, you know, we're kind of losing all of those that capacity, or you stop it because you realise it made no difference. But unless you did the study bit, now that feels really painful, because I think if you were I don't know, in a much more kind of rigid system, you could probably go, we haven't got enough, I don't know, stainless steel bolts. Let's order stainless steel bolts. Stainless steel bolt problem solved. Right, okay. There ain't none of those in healthcare. I wish there was. But yeah, so that kind of curious mind, I think, is very important around the business of healthcare, and particularly in a complex kind of multi-armed organism like the NHS.
That's very interesting.
Yeah. But it's the same in Australia. That's fine. I worked for I've twice had 2 stints working in Australia for a year, and it's quite a beautiful part of the world. And yeah, I think, you know, you see the same problems manifesting in different ways in different healthcare systems.
So to go back to that previous question, then, what would you say are the best things about the NHS that others should copy?
Okay. So I think that there's an ethos in the NHS, and you very rarely meet somebody who doesn't want to do the patient best for the patient in front of them. And I think that model works pretty well. And the underlying system usually lets most people do that. There's been notable exceptions of failures of that. I'm not going to name any kind of the big cases or the big trusts that have had issues. It does break down sometimes, and generally most people turn up to the healthcare system wanting to do the right thing, and most of the time they can find a way to do so. It's not always obvious, but they can find a way to do so. I think that's good. I think the universal coverage works very well, but we just need to be careful that we don't then rely on that it's always going to be there as a safety net, and there may need to be some changes in the coming years unless we can improve the business of healthcare, and I don't mean privatize it. That's get into politics.
Just the mechanics of it.
Yeah, the mechanics of it, and the slickness of it, and the use of technology and other systems to bring that together. So I think I'm going to slightly modify the question, because there's one that I want. There's a form of that question that I'm going to answer is, what should they do that we haven't done? Well, the first thing is, don't learn it over 75 years or however long the NHS has been in place without stopping doing things. And what the NHS is fantastic at is starting things and realizing it needs a sticking plaster and needs it. And they very rarely do they need to go, this is now complex, let's kind of go back to zero and start again. You can't do that. Can you imagine if our Prime Minister had stood up at the other week and said, we're just going to stop the NHS for a year, and when it restarts in a year time, it's going to be fantastic. Can't do that. Can't do that. You've kind of got to rebuild the bicycle or riding it. Probably building a plane to fly while riding a bicycle, and you've got to put, metaphor doesn't really work. But anyway, and so how can other systems, and I'm having this with the North African country that I'm working with at the moment, they go, oh yeah, I don't think we want to recreate what the NHS is doing. I go, no, but learn from the 75-year journey. When we've experimented with, I don't know, I've only been in healthcare for 20 years, so I'm still a new boy to it. But, that I've been through many different models of, encouraging the private sector, and then having it, and then activity-based funding models where people get paid for activity. And then what you suddenly find is there's lots of incentive to do more than you need to, and not adopt more efficient ways of working. And now we're changing that again to integrated care. And it's interesting. The NHS at the moment has got a 10-year plan. It's great. But there's a lot of things in there that have been in there that could have been there 10 years ago, 20 years ago. And I'm actually a great believer that the NHS knows everything it needs to do somewhere to make itself a whole load better. There's a phrase, isn't there, that the future's already here, it's just unevenly distributed. I think the answer to NHS problems is already here, it's unevenly distributed. I see a lot of entrepreneurs who have got technologies. There's one that I'm closely involved in, which is, bringing, if you like, the brains of an integrated care consultant, and it pulls data together in a way that it would take, resident doctor 45 minutes, and that can do that in like seconds, because in the cloud and whatever. Really hard to get that adopted to the healthcare system in the NHS, talking internationally, and they go, oh wow, so we don't need to do that thing where, somebody has to pull up a spreadsheet and a slide rule and and get their pocket calculator out and whatever and do that stuff. That's possible. You go, yeah, it's possible. So I think I would say to the systems that are starting with, shall we say, more of a blank page, they can adopt some of that. And I was talking to, I won't name drop which country it was, a health minister of a very large Asian country, just a couple of weeks ago, and the energy with which he said, I've got this population that's spread across many, many islands. In the past, there'd be bad coverage because all the workforce was in the wrong place. And he goes, now we've got Starlink. So I've got better connectivity between all of my systems and all of my populations than I've ever had. So I haven't got to feed cables through or fiber optics. I haven't got to wait for that. He said, but now I've got Starlink. I've got to find something to do with it. Well, the answers are out there. He's just got to find them and get them to plug together. That's the next thing I would say, that the NHS, and we've just had an announcement that it's going to be NHS Online. It's going to be an evolution, I think, is make sure you're buying Lego and not lots of non-standard stuff that doesn't plugged together, and kind of say, look, if you want to play in this system, you've got to be good at Lego. So the blocks all go together. Don't care what color you've got, and I don't care if it's technical Lego or, you know, the one that builds the Millennium Falcon. But let's make sure that it all plugs together, because there's a natural view, particularly in business, that I'm going to have my system and I'm going to have it closed. Well, the buying power of the NHS is saying, that's fine. If you want to do that, you don't get to play in this $200 billion system, £200 billion system. So, and that's called interoperability. That's, so I'd say, make sure you have, you know, you ruthlessly say that, whether it's technology, whether it's, I don't know, surgical consumables, or whether it's, I don't know, even to some degree, staff training. We haven't even talked about this, the worldwide shortage of healthcare workforce yet.
I mean, it's a bit
come down in a bit, I'm sure. I don't know, we might run out of steam by now.
But on this idea of interoperability, right? I come from a background of software where you have APIs.
Yeah, I know what an API is.
Right? It's all about connecting to each other.
And something happens in the black box. No, your intellectual property sits in the black box, and I'll tell you how to work to it by the cables that are hanging. Yeah.
But as you mentioned, the NHS is almost a system of plasters. And so is there, obviously, having this idea of interoperability, especially like health tech, because as you said, but having health techs, they would love to, there's, you know, the NHS clinical entrepreneurs, they would love to bring their, you know, amazing products. But on the other side, speaking to clinicians, they have this fear, for many fears actually, but if I name a few, one of the big one is a lot of these entrepreneurs, they're not clinicians. They don't really understand the pain points of a clinician. Or another big one, you know, I've heard recently is that this clinician who works in the emergency unit, they said, look, I get these dashboards sound really good, but they're actually working, you know, 12-hour shifts. They can't even be bothered to learn like a new dashboard, for example. So what's the, I guess the question was, what's the right way to go about this?
So I have to say that the you know, I mentioned the intensive care, the guy who's running that is a clinician, and I think this is really important that that we do have a bunch of people. Actually, I had somebody once said to me, what do you know about healthcare? Have you ever run a hospital? And I go, no, I haven't. You're absolutely right. I have never run a hospital. But what I have done is I've worked with people who have, and clinicians. So I bring a different perspective. I'd like to work with you. I do not want to come here and tell you your job. And I think that kind of works in healthcare, that if you can get, first of all, most clinicians will disagree with each other about what things look like. So it's kind of comes back onto the industry and the technology industry to say, actually, here's a view. Yeah, and if you look at how systems have changed, if you think about systems from 25 years ago, they're all little drop-down menus, and you know, you had your mouse and you kind of clicked on it, and it didn't have the things you want.
You'd be lucky if you have a mouse. Like,
exactly.
More recently, it's just keyboard.
So I cooked a roast at the weekend. This is going somewhere. So a few years ago, I'd have gone to Google and said, I had an AI tool. I pressed the speaker button. I said, I've got a whatever size joint. How long should I cook it for to perfection? It talks back to me. That wasn't possible probably 6 months ago. I'd have burnt my roast, or it had been like pink in the middle. Everyone had got some disease. We've got no excuse now not to have interoperability because of, you know, just the power of computing that we've got in our pocket, and the skills people have got for building user interfaces. And I know from stuff I've seen evolve, it was like stuff had a really clunky user interface like 15 years ago, and then it had a really neat kind of Star Trek-y interface where people say things, and now people are just talking to things and it's answering back. So you kind of have gone through a lot of that. And I think there is a thing about trust as well, which is, we all know that AI systems hallucinate. And the last thing you want to do is, and I go in with a burst appendix or whatever, and somebody describes symptoms and amputate both legs, and go, oh, anyway, I'm sure I wouldn't be. I'm sure that would never happen. But I think we've now got the time of the technology, and I'll go back to the major Asian country. I mean, what a great position to be on. He's got some grants, he's got some leeway, he's got some infrastructure. Let's try some things and put the controls in place. And I think we're in the same way that we're a long way off autonomous vehicles. We're probably a long way off illuminating that real kind of, you know, they've done their 10,000 hours, they know how to be clinicians. and they rely on science, and they've got the right ethical framework to look after people. We're a long way off eliminating those guys, but what we can do is we can multiply them by the technology, so they don't have to be in the same place. Or the person who is in a different stage of their career, or they've decided that they want to be healthcare assistants, or they want to be they want to be in the real kind of real human side of the care as well as the scientific side of the care. They could have access to some of this stuff, and the AI bot goes, this is the time to take it to the next level. And that makes things safer. It also multiplies those scarce resources, because there ain't enough healthcare professionals in the world.
What do you think the future of healthcare is going to look like, given your experience as a consultant in healthcare?
Okay. That's a big question. I wish you'd asked me that at the beginning, and I'll have an hour to think about it. So I think the future of healthcare is, I think we're going to be a lot more open about our data, and I don't mean kind of what infections I've had and whatever, but I'm wearing a watch at the moment that is able to check my heart and other things. A few weeks ago, I won't name the podcast, but I did the whole thing, where you wear the blood glucose monitor and they give you a big green biscuit and you eat it and it tells you, and because of that I've worked out I'm having rubbish for breakfast, so I'm now having better breakfasts, and so all of these things, I think we're going to start using that knowledge probably to nudge us to do healthier things. So I think there's a lot more well-being out there, and I think and I think coming back to the business of healthcare, good food options are available. We need to make them much more universally available, and make sure people aren't doing things kind of at the injury kind of
the preventative
the preventative side, and so I think we're going to get exactly, it's can we do prevention rather than care, but it's that most of that isn't about health. If you look at the major gains in life, in childhood mortality through to longevity, a lot of that is around vaccination, putting fences around large open areas of water, and health and safety and all of that stuff. As I say, vaccination and clean water, making sure your water, and so all of that kind of public health and at the good end of stuff. That will be good. I think somewhere in the middle, I think we are going to see some pretty neat personalised medicine. They've only been talking about it for 25 years, but I think you're going to find, something that works on you might not work on me, and it might not work on somebody else. But actually, if we can fine tune it, suddenly you've got a vaccine for a certain type of cancer or something. Or it may even be that actually I'm at risk of that cancer. But if I can take something, that may mitigate that risk.
So it sounds as though it's open data and personalised sort of care.
Yeah, well, you just say the future. I'm thinking along the stuff we can do today, the unevenly spread stuff, interoperability. Getting the data there, and just some useful stuff. I think is kind of the near future. The far future, well, okay, then I'm off to one of my science fiction films, aren't I? Anyway. Yeah.
Andy, I learned so much from you.
Anyway,
this conversation. That was such an interesting one, especially learning how you, as a consultant, go into a system and try to improve it, find the gaps, but then also your thoughts on the future of healthcare. It's very interesting. Thank you so much for this conversation.
That's great. Thank you very much. Pleasure. Thank you.
Thank you.